40% of hypertension patients don't respond to treatment, not because therapy fails, but because we're targeting the wrong system. And what I'm about to show you could completely change how you think about blood pressure. What if the reason your patient's blood pressure isn't improving has nothing to do with their diet, their compliance, or even the medication you prescribed? What if, despite doing everything right clinically, we've been targeting the wrong system altogether? Because for decades, hypertension has been treated as a vascular problem. We focus on the arteries, we reduce volume, we dilate vessels, we adjust lifestyle factors like sodium, weight, stress. And while that works for many patients, there's a significant subset, nearly 40% globally, who remain resistant to treatment. These are the patients who follow guidelines, take their medications consistently, and yet their blood pressure refuses to normalize. And as clinicians, that creates a frustrating dead end. So the real question becomes, what are we missing? Recent research from collaborative teams in Brazil and New Zealand suggests something quite disruptive. Hypertension, at least in a large subset of patients, may not be primarily a vascular issue at all. Instead, it may be rooted in a specific neural circuit located deep within the brainstem, specifically a region known as the parafacial lateral region, or PFL. Now, under normal conditions, the PFL has a very specific role. It's involved in forced exhalation, so activities like coughing, laughing, heavy breathing during exercise. These are not passive respiratory actions. They require active muscular engagement, and the PFL coordinates that response. For a long time, this region was considered purely respiratory in function. But what researchers discovered was unexpected. In hypertensive models, particularly in animal studies, the neurons in this region appeared to be cross-wired. Instead of only controlling respiratory effort, they were simultaneously activating the sympathetic nervous system. In other words, every time this region fired, whether due to breathing stress, oxygen imbalance, or reflex activity, it was also triggering vasoconstriction. That changes everything. Because now, something as routine as altered breathing patterns, repeated coughing, or subtle physiological stressors could be generating repeated sympathetic surges. Not occasional spikes, but chronic, repeated activation over time. And this is where the connection becomes clinically relevant. Think about sleep apnea. We've long known there's a strong association between obstructive sleep apnea and resistant hypertension. Patients experience repeated episodes of airway collapse, oxygen levels drop, carbon dioxide rises, and the body is forced into emergency breathing responses. What this new model suggests is that during those episodes, the PFL is repeatedly activated, not just to restore breathing, but inadvertently triggering sympathetic outflow and vascular constriction each time. So instead of a purely respiratory issue, we're looking at a neurocardiovascular feedback loop. Night after night, episode after episode, the brain is effectively training the cardiovascular system to remain in a heightened constrictive state. And because this process is subconscious, occurring during sleep, traditional interventions like reducing sodium or prescribing antihypertensives don't fully address the root cause. This could explain why so many patients plateau despite aggressive treatment. Even more compelling is the experimental validation. In controlled studies, researchers were able to selectively deactivate the PFL neurons in hypertensive animal models. The result? Blood pressure normalized, not partially improved, normalized. And when those same neurons were reactivated, hypertension returned. That level of reversibility strongly suggests causation, not just correlation. Now, of course, directly targeting the brainstem in human patients presents obvious challenges. The brain is protected by the blood-brain barrier, and any pharmacological intervention risks affecting multiple critical functions: respiration, cardiac rhythm, baseline autonomic control. It's not a viable or safe direct target, but this is where the research becomes particularly elegant. Instead of focusing on the brain itself, researchers traced the signaling pathway backward. They asked a simpler question: What is triggering the PFL in the first place? And the answer lies in the carotid bodies, small clusters of chemoreceptors located in the neck, adjacent to the carotid arteries. These structures act as primary oxygen and carbon dioxide sensors in the body. When oxygen levels drop or CO2 rises, they send signals to the brainstem to initiate corrective breathing responses. In essence, they are the alarm system. So rather than trying to disable the alarm inside the brain, researchers are now exploring ways to modulate the signal at its source, at the level of the carotid bodies. By reducing or quenching their hyperactivity, it may be possible to prevent the excessive stimulation of the PFL altogether. This approach bypasses the blood-brain barrier, reduces systemic risk, and offers a far more targeted intervention. Of course, it's important to emphasize that this is still early-stage research. Most of the data comes from animal models, and human physiology introduces additional layers of complexity. Clinical trials will be essential to determine safety, efficacy, and long-term outcomes. There are also important considerations, such as how modulating oxygen sensing might affect responses to exercise, altitude, or acute stress. But even at this stage, the implications are significant, because this represents a shift in how we conceptualize hypertension, not just as a mechanical issue of pressure and resistance, but as a neurophysiological condition involving misregulated signaling pathways. It moves us from treating symptoms at the level of the vessels to potentially addressing the control system that governs them. And perhaps most importantly, it reframes how we view treatment-resistant patients. Instead of assuming non-compliance or lifestyle failure, we may need to consider that, for some individuals, the system itself is wired differently, that the pathology isn't in what they're doing, but in how their body is responding at a neural level. So the next time you encounter a patient whose blood pressure remains elevated despite optimal therapy, it raises an important question. Are we treating the right target? Because if this line of research continues to hold true, the future of hypertension management may not lie in stronger drugs or stricter guidelines, but in understanding and correcting the hidden neural circuits driving the disease in the first place. And that could fundamentally change everything.